Okay, so antepartum. Just the word alone kind of indicates what we're talking about in the pregnancy. Partum just meaning basically the delivery aspect. Okay, so when you put ante before it, that prefix just meaning prior to, so before delivery. So if you think of ante, like a poker game, you ante up prior to playing, you put in your money or whatever. So it's before. So ante just meaning before delivery. So um, with this, um, obviously, woman needs to be pregnant. So a lot of times there are changes and signs that the woman may feel or be observed by an examiner that could possibly indicate that somebody is pregnant. Okay, so we categorize those into three different categories: presumptive, probable, and positive. So presumptive is basically subjective data from the patient. Okay, so it's purely subjective data. That she could be fatigued, have some breast tenderness, nausea, vomiting, amenorrhea, just meaning she's not having her periods, urinary frequency, fetal movements, those type of things. So these are just subjective data. These are just presumptive. This does not mean the woman is truly pregnant. Okay, there's a lot of other reasons to have these symptoms. Okay, even we call it fetal movements, but a lot of times that's what they think they're feeling, but it's gas and things like that. And then we can move to probable. So it's a little bit higher chance that maybe the woman is pregnant, but still not a definitive diagnosis. So probable is more objective data from the examiner. Okay, so that's the difference between the presumptive and probable, is that subjective and objective data. The probable data requires an exam. So most of these are obtained through a vaginal exam by the examiner. So looking at the Hagar sign, so when in that exam, they're feeling that softening of the lower uterine segment, the Goodell sign, kind of that softening of the tip of the cervix. Ballottement they'll feel on that exam, which is just where when they do the exam, if they gently palpate the cervix or that lower uterine segment, they can kind of feel like they're bouncing what would be the fetus inside the uterus. Okay, again, it could be something else. It could be a tumor, a growth, anything else. So again, it's not truly indicative of pregnancy. It's just another indicator. If the examiner feels some type of Braxton Hicks contraction, so some type of tightening in the abdomen, and a positive pregnancy test. So whether urine or serum, again, that's not confirmative of a pregnancy. There are reasons for positive pregnancy tests that are false positives. Okay. The actual positives of a pregnancy, these are definitive diagnoses. These confirm pregnancy. So if we can either auscultate fetal heart tones, okay, using a Doppler or a fetoscope, just different instruments to actually listen to and hear the fetal heart tones inside the uterus. Fetal movement felt by the examiner and visualized by the examiner. So the examiner actually putting their hands on the mom's belly and actually feeling and seeing those movements. And then ultrasound verification. So visually seeing that fetus within the uterus on ultrasound. Okay, so these are your yes, for sure, yes, you are pregnant signs. Okay, so be able to kind of, differentiate between these signs. Okay. So if we decide, yes, yay, mom, she's pregnant. So what are we going to do? How do we move forward? How do we follow this mom? What's the best course of action in making sure she has a healthy pregnancy? That first prenatal visit, getting a good health history, just medical surgical history, but also her obstetrical history. So previous pregnancies, if she's had anything like that. Obviously a nice physical, history, head to toe exam, all of those types of things, and we'll grab some labs. And this next slide goes over some of the labs. A lot of these, hopefully you have been seeing in the clinical setting. So hopefully you're starting to be able to differentiate between these and understand why we obtain, some of these labs. So majority of these are obtained on that first prenatal visit. So we want to get her blood type and RH. Keep in mind, blood type is just the letter of that blood type. So whether it's A, B, O, whatever. And then RH is whether it's positive or negative. Okay. In the antibody screen, is part of that type and screen test, just looking to see if there's any antibodies within the blood. Okay. Hemoglobin, hematocrit, CBCs, VDRL or RPR. So those are just two different types of tests, but they both test for syphilis. HIV, hepatitis B surface antigen, rubella. We want to make sure that mom is immune to rubella because it can cause some birth defects and things like that if mom has contracts rubella. A UA, a pap smear, so like we talked about last week, so looking at collecting cells from that cervix to look for possible cancer-causing cells within that. Cervical cultures, usually they'll do a gonorrhea, chlamydia culture, if need be, any other cultures they think are needed to see if there's any infections going on. Because when a woman has an infection, a vaginal infection going on, that can affect the pregnancy, keep the pregnancy from being maintained, and also cause complications within the pregnancy. And then renal function, making sure that mom's kidneys are functioning well. So she's going to have to start filtering and processing for two now, her and the baby. So we need to make sure those are functioning well. And then there's some to the right of this during different times and times of the pregnancy, we'll do some different tests. So usually around 16 to 18 weeks, we'll do that MSAFP. So you'll see that on your clinical data tool. Sometimes it's just called AFP, and it just stands for maternal serum alpha fetal protein, or AFP, alpha fetal protein. That is a protein hormone released by the baby that if that level is increased that they find can be an indication of neural tube defects, chromosomal abnormalities, Down syndrome, things like that. So the AFP tests for that, more the neural tube defects. The triple and quad screens, the more testing is done, it's a little bit more it looks for different markers, so more chromosomal abnormalities. So the quad screen just tests for more, 4 of them instead of 3, like the triple, and that type of thing. But it's all testing for, same thing. 16 to 20 weeks, fetal survey, that just means an ultrasound. So they're doing an ultrasound around that time. They're looking to see is that fetus the correct size in relation to how far along the pregnancy is. They'll look at anatomy of the baby, make sure all the anatomy is there and appropriate and functioning, that type of thing. A lot of times they can tell the sex of the baby around this time. So that's done then. And then around 24 to 28 weeks, they'll usually do some type of glucose. Can everybody mute their microphone?
I have a question.
Yeah. Oh, yeah. Sorry.
For the, what is it? The MSAFP, is that what they do at amniocentesis for, or is that totally separate?
That's separate. Yeah, this is just a blood test. Yep.
Okay.
Yeah, we'll talk a little bit about that amniocentesis a little bit later. Yeah, it's different though.
Okay.
Good question. Okay. So the glucose challenge test, looking to see if mom has some type of gestational diabetes. So moms can develop diabetes just during the pregnancy. They may not have had any complications before. And then after the pregnancy, a lot of times it goes away, but it does increase the risk of developing it later in life, though. A CBC they'll do just a recheck, make sure everything's functioning well. She's not getting anemic. Her platelets are good. No signs of infection, things like that. And then also closer to the 28 weeks, but within that time frame, RhoGAM will be given if needed. So if mom is a negative blood type, so Rh negative, those moms, all of them need RhoGAM at by 28 weeks. Okay, and that's to help prevent any antibodies being formed in the mom's blood that could fight off a positive blood type. So if baby is a positive blood type, that's what can occur. Negative blood type of mom can fight off babies and cause a lot of complications, ultimately death even in the baby if those antibodies are formed. And what was I going to say about that? So again, just your Rh negative patients need to get that. Was somebody going to ask something?
Yeah, I'm sorry. Could you please repeat the RhoGAM if indicated? I just have that it's for moms that are age negative and why we need it.
Yep. Yep, so just your Rh negative moms, and it prevents her from developing antibodies against an Rh positive fetus. So because we don't know what blood type baby is, we have to assume the worst, and the worst would be if that baby is a positive blood type, Rh positive. Okay. If baby's a negative blood type, it would, because it's the same as mom's, it wouldn't be a problem. But we're not going to do an invasive test to see, it's not needed, to see truly what blood type baby is. So we just assume, we want to prophylactically treat to prevent it in case baby is a positive blood type. Okay, so prevent those antibodies from being formed within the mom's blood that could fight off that baby's blood. Okay, did somebody else have a question?
I did. Is this given at 28 weeks or can it be given before if they know that there's
It should be between this 24 to 28 weeks.
okay.
20 most places will do it 26 to 28 weeks, trying narrowing down that window. Usually don't want to go past the 28 weeks, so within that small couple weeks of window. Okay.
And then there's a question on chat too. I'll just read it. If father is negative, would the mother need RhoGAM?
So good question. Sorry, I didn't. My chat wasn't scrolled down. Thank you. So because so there are some women that will refuse it because they know for sure who the father is and the blood type and that type of thing. And they can refuse it, but ultimately, it's not the best idea. And they try to discourage that just in case, because a lot of times it ends up not being the father or they think it's the father. And then it can be deadly to the baby. So, but yeah, good question. I mean, if it's 100% we know for sure, then no, she wouldn't need it. So, okay. Okay. And then around 36 weeks, they'll do a GBS or group beta strep culture, and that's just a vaginal kind of perineum and rectal swab all in one, that they swab to look and see if the woman has group beta strep growing there. It's not an STD. It really doesn't cause much harm to the mom, but it can be deadly to the baby. So if baby delivers vaginally and passes through that GBS, it can cause infection, meningitis, ultimately death in the baby if left untreated. So we want to know that. We tested around 36 weeks because we want it kind of close to delivery. And if mom is positive and she comes in labor, and she's going to deliver vaginally, then we want to treat her with some antibiotics. We'll usually give penicillin is the ideal course, unless they're allergic. Then it's usually clindamycin or something. But and they should get 2 doses of that within 4 hours apart from each other and within 4 hours of delivery. So she may get several doses if she continues in labor for a long time. Okay, every 4 hours. And that's to help prevent that from being passed on to baby. If mom delivers via C-section, then we don't treat her for it because baby's not passing through that vaginal tract. All right. So that was kind of your initial visits. Ongoing throughout the pregnancy, those follow-up visits will include, continued physical exams, some periodic labs. Education is huge and important to make sure that we identify any complications early so we can intervene. Making sure the woman understands the importance of prenatal care. Prenatal care is like vital to a successful pregnancy. It helps reduce morbidity and mortality in this population, so it's really, really important. Nutritional needs, making sure mom's getting what she needs so baby gets what they need, that type of thing. And then just monitoring the fetus for making sure mom's feeling it move once they get to a certain point in the pregnancy, measuring the fundal height, and we'll go over that in a few slides here, and listening to the heart rate, making sure that sounds appropriate and it's there. So, okay. And then we'll also, or another part of the assessment of the pregnancy is looking at this GT-PAL, the McDonald's method of fundal height measurement, and this Nagel's rule, and we'll go into this a little more detailed. So your GT-PAL, hopefully you guys have had some exposure to this within the clinical setting, collecting this data and trying to figure out, what this means to your patient in her history. So this is also in your OB survival guide and the clinical paperwork, so it talks about it there, and obviously in your book too. But so G just stands for gravida, which means how many pregnancies the woman has had. Okay, it doesn't matter what's happened to them, it's just how many times she has been pregnant. Okay, and if a woman was pregnant with twins, it's still one pregnancy though. Okay, so it's still, if she was just pregnant one time with twins, it would still be gravida 1. Okay. The T stands for term, and this refers to any delivery. So mom would have had to have actually delivered the fetus. So term is any delivery that occurs at 37 weeks or further along in the pregnancy. Okay, remember we kind of talked about this when we talked about the newborn, with like preterm babies, less than 37 weeks and that type of thing, and term babies are 37 weeks or more. So same thing. So term, and then the P stands for preterm. So any delivery that occurs between 20 weeks to 36 and 6/7 weeks. Okay, remember we measure the gestation in not just weeks, but also days of that week. Okay, so 36 and 6/7 means the woman has completed 36 weeks plus 6 out of 7 days of the following week. Okay, so if she went one more day in the pregnancy, she would be 37 weeks, be considered term. Okay. And then the A stands for abortion, which is any delivery that occurs prior to 20 weeks. Okay. And keep in mind, abortion, that word, that term has a negative connotation to a lot of people, but that is the medical term for any delivery prior to 20 weeks. It doesn't matter how it occurred, if it was a spontaneous abortion, a miscarriage, or a therapeutic abortion, or an induced abortion where somebody went to have the pregnancy terminated, that type of thing. Okay, so just keep in mind when you're collecting this data, though, using that term, a lot of people only think when you say abortion is where they went to have it induced, have that pregnancy ended. Okay, they don't think of a miscarriage, they call it as being an abortion. So when I use these terms, when I'm asking the patient about previous pregnancies, usually we'll ask them, how many times have you been pregnant? What happened with those pregnancies? To find out abortions, I'll usually say any miscarriages, any abortions. Because a lot of times women will not mention miscarriages or abortions when we ask them about pregnancies. So we got to be a little bit more specific, but be careful of the terminology. And then L is the living. So any currently at this day of assessment, so if I'm asking today, this patient, how many of her children are currently living, okay? It doesn't matter what happened at delivery. So maybe they were living at delivery, but maybe they died yesterday. Maybe they died at birth. Maybe they died, at any time between then. It's just today, how many are still physically living. You'll see in some hospitals, especially if you're using Epic in any of the Beaumont facilities and things, you'll see just the G and the P system used. So if you're looking at the patient's chart in Epic, you'll see to the left of the screen a breakdown of her G's and P's, and it just says G and then a number, and then it says P and like 4 numbers after that. Okay, that confuses students because that P within that instance stands for para, okay, which just means basically a delivery. Okay, so but what those 4 numbers after the P stands for is and in order is the TPAL. Okay, so all this right here. Okay, so you'll see the G, you'll see a P, so just ignore the P, okay, and put those numbers in place of the TPAL. Okay, if that makes sense. If you're not familiar with Epic, or if you haven't looked at those yet. But next time you go and look at your chart in Epic, take a peek at that. Okay, but I know that gets confusing for students. Oops. All right. So in this, I just want you guys to kind of practice with trying to figure out the GTPAL of patients, and that is on the exam 1 review. So make sure you understand this process. So for this instance, if you have a pregnant woman comes in for her first prenatal visit, so we're trying to get this information. So she states that she has been pregnant 5 times and has 1 child living, okay, and then it breaks down the pregnancies. So, and this is where I wish I had a wipe erase board or something that I could do this for you guys, but so it says she's been pregnant 5 times, okay? So right there you have your gravida, okay? So she's a G5. Okay, she has 1 child living. Okay, so you can jump ahead to the L and put a 1 underneath the L. Okay, And then we're going to figure out these middle numbers and letters, the TPA. Okay. So her first pregnancy was a 12-week miscarriage. Okay. So that was less than the 20 weeks. It doesn't matter what you call it. She delivered prior to 20 weeks. Okay. So this falls under the A. So we'll have one A so far. Second pregnancy was a 40-week vaginal delivery. Doesn't matter how she delivered. She just delivered after 37 weeks, right? Or 37 weeks or further along. So this would be under the T for term, okay? Third pregnancy was a 41-week C-section. Again, doesn't matter how she delivered. It was 41 weeks, so 37 weeks or further along. So that's another T. So now we have two T's, right? We have the 40 and the 41 are both T's for term. Her fourth pregnancy was a termination at 9 weeks. Again, doesn't matter why, but it was 9 weeks, so it was prior to that 20 weeks. So that's another A. So now we have two A's, right? We have the 9-week and the 12-week under A. And then her fifth pregnancy is the current present pregnancy, okay? So the current pregnancy just counts in the gravida, because that's the number of pregnancies, okay? So we'll add another number to the G, which is the 5, okay? She hasn't delivered, so we cannot assign this pregnancy a number under any of these other letters yet, okay? Because remember, those refer to deliveries and living children, okay? So once she delivers this pregnancy, then we'll add whether it was full term, preterm, whatever, okay? All right, so just kind of practice with that. Does that make sense, how you kind of break it down? So again, keep in mind twins is just one pregnancy. Twins is also one delivery, okay? So even though maybe 2, 3, 4 babies are coming out, it's still one delivery episode, okay? So depending on the gestational age, that T or P, whatever would count is still just one, okay, for twins. What number would change with twins is the L, okay? So if a woman had twins and both babies survived, so it would be 2 current living children, okay? Does that make sense?
I have a question.
Yeah.
So for this scenario, there isn't a P, right?
Oops, sorry. Oh, correct. Yes, the P is 0.
Okay.
Sorry. Yes, the P is 0. That's right. If I was writing this on the board, I'd see that. Sorry. Yes, good question. So P0. Nothing was between that 20-week to 36 and 6/7. Okay. All right. So just kind of practice with that. Make sure when you're in
So
clinical. Yeah, you have another question? Did I hear somebody with a
Yeah.
question? Yeah, go
So
ahead.
for it to be considered an abortion, it has to be less than 20 weeks.
Yes. So any delivery less than 20 weeks. Okay. And remember that abortion
So say
term.
like the 21st week they have a miscarriage, it's just considered preterm.
Yes. Yep. So it falls between that 20 weeks and 36 and 6/7 weeks. So that's a preterm delivery. Yes. Okay.
Oh,
Okay. All right. So yeah, practice that at clinical. Look at your patients. Look at your G's and P's. Try and understand that, and do some practicing with that. Okay. The other thing you'll need to practice on, I'll explain, is this Nagel's rule. So this is trying to figure out and calculate when the woman would be 40 weeks pregnant. Okay. So we call it her due date. You may hear it called. The true term is either EDC, you see at the bottom, or EDD. EDC stands for estimated date of confinement, or EDD, estimated due date. They both mean the same thing, okay? It's just when would this woman be 40 weeks, okay? She estimated should deliver about that time, okay? It doesn't mean she's going to deliver on that day, but it helps us calculate out how far along she is. Is she that 37 weeks? Is she preterm? Is she term? That type of thing by figuring this out, okay? Now the computer systems do this for us, but there's still times that we need to be able to do this and figure it out on our own, okay? So what you need, and I will tell you, I have seen this on NCLEX review questions too, so make sure you understand this. So what the piece of data you need from the woman is the first day of her last menstrual period, okay? So this is where things could change. Part of the reason why it's called estimated date or due date, because it's not an exact science, it's an estimation. But sometimes women are not really sure of the first day of the last menstrual period. So it could, this is not always super accurate. When this is not super accurate or the woman is not sure, then they'll try and get an early ultrasound within those first like 10 weeks, 10 to 12 weeks, to get a good idea of how large the baby is, about how far along the pregnancy is, okay? And then come up with a due date based on those measurements. All right, so Nagel's rule. So first day of your last menstrual period, you need to use that number, subtract 3 months from that number, or that date, sorry, from that date, add 7 days to it, and then correct for the year if you need to. So remember, we're trying to figure out how far along this pregnancy, or at what point, what date this pregnancy would be 40 weeks, okay? So if we're starting off the end of the year, we know it's going to go into the next year, the pregnancy, right? So you just got to think about that year, and does that make sense? If the first day of her last menstrual period is early in the year, in January, February or something, then it's, you know, her pregnancy 40 weeks is going to stay in the same year, okay? So just make sure it makes sense. So an example, so if a woman stated that her LMP, which stands for last menstrual period, is 12, 19, 18, how would you calculate out her EDC? So I want you guys to take a couple minutes and try and figure this out. So use this date, subtract 3 months, add 7 days, and correct for the year if you have it. And then once you figure it out, you guys can start typing your answers in the chat. Okay, I'll give you a couple minutes. I already have some quick figure outers. All right, so good. So if you took 12, 19, 18, you subtracted 3 months from that, you're going to end up with 9, 19, 18, okay? And now you have to add 7 days to that. So you would come up with 9, 26, 18, okay? And then you just have to figure out, does that make sense? If her last menstrual period was December of 2018, does that make sense that she's going to deliver in September of the same year, so prior to her even having that? So it doesn't make sense. So that's why we have to correct the year to 19. Okay, move it forward. So yes, you guys are correct. It's 9/26/19. Okay. All right, good job. So, and then there's a couple other, I'm not going to go through all these, but you can use those to practice. Okay, if you are struggling with that, let me know. Okay. Okay, and then another piece of our assessment data that we'll collect is using McDonald's method to measure fundal height, to measure how big that belly is in relation to the pregnancy. So you use a tape measure. You start at the symphysis pubis, okay, down here, right at the top of the pubic bone there. And we measure to the top of the uterus, which is the fundus, okay? And we see how large that is, okay? We measure it in centimeters. This should correlate pretty closely with how many weeks gestation the pregnancy is, okay? So if a woman is 32 weeks gestation, so 32 weeks along in the pregnancy, she should be measuring about 32 on the tape measure, okay? They should correlate. So there's things that could change that. If she's having a large baby, maybe a small baby, maybe there's a growth issue. If she has too much amniotic fluid, she has twins or multiples in there, larger, you know, more babies, that can alter it. But if everything's, you know, normal, single pregnancy, that type of thing, it should correlate, okay? And that's how we're looking to see, you know, are things measuring? If things start to lag behind or they're getting larger, we may send her for an ultrasound to get, you know, confirmation, get better measurements and growth details, okay? Okay, within the uterus, floating around the baby, you have the amniotic fluid. So this is important fluid for a lot of reasons. And I make sure you understand this. I think that's on the exam review too, amniotic fluid functions. So temperature regulation, so it keeps it's like a nice warm bath, okay? Keeps a nice even temperature. Remember, thermoregulation is important for that fetus. It adds an extra layer of cushion against any trauma. So if the mom falls, gets hit in the belly, or just anything, you know, pushes up against it, it creates that added layer of cushion to prevent anything from harming that baby, hopefully. It allows for movement and musculoskeletal development, so muscle development and things like that, because it can move around. keeps the baby from tangling with the membranes. So if there was not that good cushion of fluid, those membranes would be more movable and could get tangled up in the baby, okay? We're talking about the amniotic sac for the membranes. And then it also facilitates symmetrical growth. So if that baby can freely move within there, we should have symmetrical, even growth on the baby. If there's not a lot of fluid, there's issues with that. Baby could be kind of compressed up against the side of the uterus, side of the amniotic sac, okay? So if that happens, then you could have some deformities and some difficulties in maybe this arm that's stuck up against there in that developing and growing appropriately, okay, compared to if it's freely movement around, okay? So keep those things in mind. Usually by the end of the pregnancy, there's about 700 to 800 milliliters of fluid. That's your normal amount, okay? It should be transparent, fairly clear. So that's what we're looking for if we think the bag of water is ruptured. We want to know, was it clear? The volume is dynamic, so it's kind of changes by a little bit periodically here and there because baby swallows the fluid and then it pees it out. Okay, yep, you guys all swallowed your own pee inside your mom at one point. You all did it. It changes with that depending on if baby is peed yet or not. Some of the fluid comes from the maternal blood across the amnion, so across the amniotic sac from the placenta. What is in the fluid, so fetal urination, the baby peeing, and then like I said, that what's transported across the maternal bloodstream, okay? So there's two variations. So if it's not normal, then the fluid could be maybe either too little fluid or too much fluid, okay? We look at oligohydramnios, which means not enough, means less fluid than normal, okay? So usually if it was term, at under 400 milliliters would be considered oligo. And we have measurements throughout the pregnancy that we could measure to see if there's not enough fluid. But this is associated with fetal renal abnormalities. Okay, so again, remember it's a process that baby needs to pee it out. If baby's kidneys are not functioning well, that could alter the fluid. If the uteroplacental unit is insufficient, and you'll hear that term frequently, and you'll hear it next week too when we talk about fetal monitoring. Uteroplacental insufficiency just means that that uterus and that placenta unit are not functioning properly, so they're not giving the baby enough blood flow, oxygen, nutrients, that type of thing, okay? And then ROM, rupture of membranes, not range of motion, okay? So if that bag of water has broke, obviously that fluid's gonna start draining out and you're gonna have less fluid. Hydramnios, or sometimes people call it polyhydramnios. So this is an overabundance of fluid, too much fluid, okay? Over 2,000 milliliters at term. So this, a lot of women who have maternal diabetes will have this. Multiple gestation, so if there's multiple babies in there, they do need to have a little bit more fluid, okay? But there's a point where it could be too much, okay? If there's chromosomal abnormalities with the fetus, malformations, things like that, that can increase that fluid level, okay? The placenta, I'm not going to go into a ton of detail about this because there are 2 videos posted in the course, not in Course Point, but in the regular Moodle online, HFC online. So make sure you watch those. One's really brief, I think like a minute or something. The other one is like a Khan Academy one. Make sure you watch that. I think it's like 12 minutes, but it's really informative. Helps you understand the function of the placenta. Just a couple brief things I want to point out to make sure you understand though. Know that the placenta, it's an exchange site, okay? Maternal and fetal blood should not be mixing, okay? So this is a transfusion and exchange site of gas and nutrients transferring, okay? It's not a barrier, okay? So, which is good and bad. So this means anything bad mom does, drugs, viruses, things like that can pass through this. But at the same time, mom can transfer antibodies for an immune response and things like that. So good things can transfer too. All right, so it removes those wastes and things like that. All right, some placental hormones, so estrogen and progesterone. So these are hormones that you're going to continue to hear. You've already heard these last week. You'll continue to hear these throughout women's health. These are 2 important hormones in the women's body that has a multitude of different functions. But these are also produced by the placenta. So estrogen, like we've kind of learned before, talks about breast support and things like that, but it also helps with uterine growth. But important to note at this stage is that it stimulates uterine contractility, okay? So it can contract the uterus, okay? On the opposite end, progesterone decreases that uterine contractility, so that tightness, contraction of the uterus, okay? It also stimulates breast and uterine development, though. So, but pay attention to those, the contraction function of these two hormones, okay? Because this is important to note. Throughout pregnancy, these two hormones should maintain kind of an even keel, so they should balance with each other, okay? If one or the other rises or lowers, you're going to have complications, okay? So if you get too much estrogen, which stimulates uterine contractions, this could cause the uterus to start to contract before we want this woman to go into labor. So they could have a preterm labor, preterm delivery, okay? Progesterone, because it decreases that uterine contractility, you know, we definitely want that hormone to, you know, keep that woman pregnant. So kind of help decrease that function of the estrogen so that it keeps that uterus from contracting too much and doesn't put that woman into preterm labor, okay? I kind of remember the difference between the two. I think I've said before, I have weird ways of remembering some things. I don't know. But the word hormone progesterone kind of could sound like progestation, right? So it's for the gestation meaning pregnancy, right? So it's for keeping that woman pregnant, okay? It keeps that uterus nice and relaxed, okay? So it keeps that woman pregnant. If she starts contracting, that's going to try and force the baby out, okay, and get rid of that pregnancy. So progestation or progesterone is how I remember that. Okay. And then, so think about as labor you start to get towards the end of the pregnancy, and a woman goes into labor, that progesterone level is probably increasing, right? Because she's starting to contract. I'm sorry, your estrogen level, is starting to increase because that woman is contracting, okay? All right, the lifeline of the baby coming from the placenta is that umbilical cord. So within that umbilical cord, you have two arteries, one vein. You can see in this bottom right picture, the two arteries are a little bit smaller. The umbilical vein is larger. The two arteries carry deoxygenated blood and waste away from the fetus, where the vein, it's a little bit thicker, carries that good stuff, the oxygen and nutrients from the placenta to the fetus, okay? We kind of remember it, the two arteries, one vein, by the acronym AVA, AVA. So there's two A's in the word, so meaning two arteries, one V because there's one vein, okay? It's hard to see in here, but you might be able to see that there's this little like gelatin type substance around these vessels. So this helps to protect those and cushion those from any trauma, okay? So make sure in your clinicals, if you haven't already, make sure you get to look at a placenta, you get to look at the umbilical cord, okay? Even right after delivery, if you can, watch when they cut that umbilical cord, you know, close to the baby. You can see they'll be looking for those three vessels. Are those there? And you can see that gelatin substance kind of ooze out a little bit, okay? So make sure you look at that. This top one shows a knot in the umbilical cord, so a true knot, which can occur. So umbilical cords are not a set standard length. They don't come in one length, like baby sizes. These vary. So a lot of times if you have a little bit longer umbilical cord and a lot of amniotic fluid, it's good that baby has lots of room to move around, but not in this instance because it can tangle up and actually tie that umbilical cord in a knot, okay, because the way it flips through and ties it. And if you think this is the lifeline, this is what's supplying that baby, if that knot gets too tight, that blood flow is going to slow down or diminish, and we could compromise the baby, and it can be deadly to that baby, okay? It's amazing to see some of these babies that have been born with these knots in the umbilical cords, and everything's been fine. It's amazing, but we don't want that to happen. All right. Oops. Another piece of our measurement that we look at, so we talked about the McDonald's fundal method of measuring. This kind of looks at, so not even using a tape measure really, but looking at in relation to the woman where the fundus, that top of that uterus falls, okay? So kind of if you think of these two ones I highlighted, so around 12 weeks in the pregnancy, this should be, so right here, the 12-week one should be at the symphysis pubis, okay? So if you can kind of think of the anatomy of the woman, where that symphysis pubis is, and where that is, so it's still within that symphysis pubis, very protected, okay? And then it starts to grow up where it's not quite as protected anymore by those bone structures. At 20 weeks, it should be at the level of the umbilicus, okay? So, and again, things can change this, large babies, lots of fluid, multiple babies, that type of thing. A very obese woman, that type of thing, okay? All right, and these are just some adaptations that the woman will go through with the breast changes and things like that. I'm not gonna like read all these to you, but I see somebody typed in that the baby yesterday had the cord wrapped around its neck. So that can happen in delivery for sure. That can be, again, just that longer cord, that baby getting tangled up in there. Sometimes they just slip through that. And then as delivery occurs, a lot of times we will see that, and we'll talk about that next week. You'll be learning about the changes in the fetal heart tones that you see when that cord is maybe around the neck or compressed too much. Who wrote that? Hind. I don't know, did you happen to see any fetal heart tones prior to that delivery? Were they concerned about any issues with the fetal heart tones? Any decelerations? Did you hear that weird word at all? Especially if it was wrapped around there 4 times, that's a lot. Well, I'll give Hind a second to type. I'll watch for your response, but that can definitely be deadly if if it's too much wrapped around there for sure. What she said or say? Yeah, they were trying to have her give birth quickly because he wasn't handling delivery well. Yeah, so they were probably seeing those decelerations in the heart tones getting deeper and deeper the further that labor progressed. So definitely that becomes a major issue. So then at delivery, they'll either try and unloop that cord around the neck, or a lot of times, there was 4 times, it was probably too tight. They probably had to clamp it and cut it and unwrap it before delivering the rest of the baby. Okay. All right. So good. I like that you guys are being able to start to see these things that we talk about or will be talking about in the clinical setting. So, which I think is great about OB, because I think it's one of the few clinicals that a lot of the things that we talk about you will see or at least hear about in the clinical setting, and it kind of brings it together a little bit better. Okay, so some breast changes happen, the colostrum, that initial milk production starts to occur, some skin changes, integumentary system changes, so hyperpigmentation of the skin. Anybody who's seen a pregnant belly, sometimes a lot of times you'll see this darker line going down the center of the abdomen called the linea nigra. Usually it will fade after the pregnancy. But again, just this hyperpigmentation, more vascular changes, that type of thing. Striae gravidarum, which is the stretch marks that women just love. Cardiovascular changes. So some physical changes, increase in heart size, a little bit will occur. This is related to that increase in cardiac output and volume. Total volume by the end of the pregnancy increases by up to 45%. So think about how much blood volume is circulating in that woman by the end of pregnancy, okay? And that's why these women are at such high risk for postpartum hemorrhage, because there's so much blood volume and the uterus is so vascular. So after they deliver, if things do not contract down and do not function properly, they can bleed, and they can bleed out very quickly, okay? So we need to be able to identify those and assess quickly. The PMI shifts up a little bit and to the left, so that might be a little bit different from where you're used to finding it. The pulse increases by about 10 to 20 beats. Important to note, the woman will probably feel some palpitations, especially a little bit later in the pregnancy, as that volume continues to increase and meet its maximum volume. So palpitations, especially like around 37 weeks, women may start complaining of that, and it's normal. So obviously we would assess, make sure there's nothing else going on, but just palpitations is normal, and that's due to that increase in volume and increase in heart rate that the woman has. Okay, blood pressure is basically unchanged though throughout the pregnancy, so the body's able to normalize that. What else do I want to tell you about that? So the palpitations, also something that you will see during pregnancy and that we need to be cautious of is something called supine hypotension. So that's where the blood pressure can be altered based on the position of the mom. So we never want the mom laying flat on her back. That's the worst position for a pregnant woman because it compresses all those vessels that have a large volume going through them. And it can really cause hypotension in that blood pressure in the mom, which think about if mom's blood pressure drops, what's going to happen to the blood flow to the baby. So it can have detrimental changes to that baby. All right, blood changes. So again, like I said, that blood volume increases quite a bit. We have some hemodilution. So the red blood cells do not increase. They do increase, but not at the same rate as the actual plasma volume. We call that kind of hemodilution. So it's not that there's not enough red blood cells, it's just that it's more diluted. It's like, filling up a cereal bowl full of milk all the way to the top. So that's your blood volume. And then throwing just a handful of Cheerios in there as your red blood cells, okay? You could throw in 50 Cheerios, okay, and still have the same amount of red blood cells, but because of how much milk, how much volume you have in there, it'll seem like there's not enough red blood cells, okay? So if you just put a less amount of volume, still the same 50 Cheerios in there, same red blood cells, again, you still have the same amount of red blood cells, okay? But it's just, we call it hemodilution because there's so much volume around those red blood cells. These patients are at increased risk for blood clots, okay? So your clotting factors increase in pregnancy, but then also your fibrinolytic action decreases. So that fibrinolytic action, that process of decreasing clots decreases, okay? So you have increased clotting factors, decreased fibrinolytic action, okay? Also, these, along with the venous stasis, so that pooling of the blood that occurs in women's extremities during pregnancy, really increases that hypercoagulability for those women, okay? So we really want to make sure we educate them on risk factors, signs and symptoms of blood clots, what to report, and make sure we're assessing that at the visits. GI changes, so nausea, vomiting, pretty common in pregnancy. It fluctuates throughout the pregnancy. Usually it's in the first trimester. Typically goes away, but not always. It can last the whole pregnancy. Okay. Different cravings, changes in taste, things like that. When a woman's anemic, they can have what's called pica, where they crave ice and then sometimes just non-food items like clay, starch, things like that. That occurs. Well, I actually had a patient one time who was very anemic. And every time I walked into her triage room, she kept shoving something under the covers. And I'm like, what the heck is she? I was trying not to be too, invading her privacy too much, but trying to figure out what was going on. Come to find out she had like a container of starch that she was like eating by the spoonfuls periodically. Mm-hmm. Oh, nasty. But that's just what they were craving because of that anemic state. So it happens. Gums can get a little swollen, bleeding, things like that. Gingivitis type things can happen. Excessive salivation, okay? That excessive salivation can increase that nausea and vomiting, okay? Because there's so much extra saliva. Esophageal tone decreases. Peristalsis decreases, so that movement of the bowels decreases. And then we give these women prenatal vitamins, iron, things like that. So these women can get very constipated very quickly and very easily. So we really want to make sure we try and counteract that, make sure they're well hydrated, eating properly, maybe giving them stool softeners and things like that. And this is just a good depiction of what occurs as that fetus grows, how the stomach gets very compressed, the liver gets pushed up. This baby is sitting on the bladder, so that gets compressed. That's why women have a lot of urinary frequency and urgency, leaking urine sometimes just from that anatomy of where that baby is placed. Some renal system changes that happen. So those kidneys, again, they're starting to function for two. One of the big things, make sure you pay attention to that first and third trimester, so the beginning and the end of the pregnancy. Women have a lot of urinary urgency and frequency, okay, due to the changes in the structures of the kidneys and the ureters and things like that. They get a lot of backflow of urine a lot of times, which can cause pyelonephritis, so that inflammation of the kidneys, urinary tract infections. So they're at higher risk for that. Okay. That progesterone, remember, that relaxes things, so it decreases that bladder tone also, so which causes that woman to have that urgency and frequency a lot also. What else do I want to tell you? Another thing you may see, so we check women's urine periodically in the visits, looking for ketones to make sure they're well, good nutrition. Body's not in starvation mode, but also looking at protein. So that starts to be alarming if that starts to get too high. A trace amount of protein is normal, is okay in pregnancy. But anything more than that starts to be concerning. Are there issues with the kidneys? Is there concerns with blood flow to the kidneys? Sometimes due to elevated blood pressure and things like that, that could cause detrimental changes to those kidneys. If you think about, this body is processing urine for 2 now, you start to have an increase in amino acids and things that need to be filtered by the kidneys. And sometimes that amount, that level exceeds that capacity of that filtration system. So it starts to spill over that protein. That's why you see it excreted in the urine. And then these are just some good pictures of where early in the pregnancy, how the spinal curvature changes in the woman up to the 40 weeks. So we call this lordosis, this extra curvature of the spine that occurs to try and help compensate for that large abdomen with that fetus in there. Okay. This is why women have a lot of back pain in pregnancy. Okay. The endocrine system. So again, we've talked about estrogen and progesterone. So I'm not going to go into too much more detail about those. HCG, so that's that hormone that you'll see show up on those early pregnancy tests. That's what helps maintain that pregnancy early. That hormone has that function. HPL, human placental lactogen, so that's the pregnancy growth hormone. Okay, so this helps facilitate breast development also, that type of thing. But really focus on the estrogen and progesterone for the most part. Okay, don't stress too much about the other 2 hormones. Just kind of have heard them before. Okay. Let's see. Discomforts of pregnancy that are common to women that you'll hear them complain about. Breast soreness. They will, start to fill up with milk. Do they just increase in size? The hormone levels, things like that, changes that. The urinary frequency we talked about. Fatigue. The body is working for 2. It's, as that fetus grows, it gets very tiring. It's taking a lot. Fetuses are parasites, technically, okay? They feed off the mom, and they will take what they need from the mom, okay? So even if the mom is not eating as well as it could, or she could, that fetus is going to take everything it can and what it needs from that mom, okay? And the mom's going to end up being depleted. Nausea, vomiting, nasal stuffiness due to those hormonal changes, gingivitis, we talked about, so inflammation of those gums and things like that. Mood swings because of the hormone changes. Okay, so these are a lot that happen early in that first trimester that you'll see. And then these are common discomforts as the pregnancy continues in that 2nd and 3rd trimester. Okay, I'm not going to read through all these for you, but just kind of review those. We talked about a lot of these already. All right. And just adapting to the pregnancy, making sure when we do our assessments and we do our intakes of our patients, finding out where this patient is coming from. Was this a planned pregnancy? Was it not? What's going on in the home environment? Does the woman have a support system? Are there cultural, religious factors that come into play with this pregnancy and how they deal with it and handle changes amongst the family? So this pregnancy is influenced by a lot of different factors, and every woman's situation is different and where they're coming from. So we'd have to, take a peek at that. It's stressful. It's not easy. There's a lot of stress that takes place. And you'll see when we talk about in some later lectures, domestic violence and things like that do increase in pregnancy because it can be a very stressful time in a family's life. Self-concept changes, kind of, that overwhelming feeling of being able to prepare for parenting and things like that. Assessment of fetal well-being. So we kind of talked about some of those things that we're looking at through those follow-up visits. These types of things we're not doing at every visit. We will do these periodically throughout the pregnancy as needed. The ultrasounds, like I said, that 16 to 20 week ultrasound, all women should have. But then if we notice any complications, problems, maybe baby's not growing appropriately, or we suspect some complications, they may do further ultrasounds throughout the pregnancy. Doppler flow studies, again, not done all the time, but if we suspect some type of blood flow issue, they can look at the flow of the blood through the placenta to the baby and that type of thing, make sure that's adequate. The alpha fetoprotein we talked about already, so looking at that protein, looking for neural tube defects and chromosomal abnormalities, Down syndrome, things like that. The amniocentesis, so someone had asked me earlier about that. So again, not all women get this, but if we suspect any complications, what they do, this is done under ultrasound. They have a needle guided by ultrasound that they go in through the woman's abdomen and withdraw some of the amniotic fluid out and send it to the lab for testing. It can look at different chromosomal abnormalities. It can look at different genetic testing. It can look at fetal lung maturity. So a lot of times we will use this if we think we need to deliver this mom earlier than that 37 weeks. So we never want to deliver a baby early if we don't have to, but if there's a medical reason or if there's a reason why that baby is not going to do better in utero, then we need to get that baby outside and see if we can help it better outside of the uterus. Okay, but we want to try and make sure that those lungs are mature when we deliver that baby. Okay, so they can test fetal lung maturity by that amniocentesis also. Chorionic villus sampling, again, this is rarely done, not very often at all, but it can give more determining factors of more further chromosomal abnormalities, more genetic testing, Down syndrome, again, cystic fibrosis. It's a more definitive diagnosis, okay? Where some of the AFP and that type of thing that also tests for that, it just gives a reference range to say maybe this woman is at higher risk for Down syndrome or neural tube defects. It's not a definitive diagnosis, okay? Where some of these chorionic villus sampling is a definitive diagnosis. Non-stress tests, so if you've had any in your clinical setting, watched anybody with fetal monitoring, we're continually doing non-stress tests. We also sometimes have patients come in for this, looking at putting them on the fetal monitor, and this is what kind of next week's lecture we'll talk about, is that fetal monitoring. We're looking at the baseline fetal heart tones, we're looking at different alterations and accelerations in the fetal heart rate, that type of thing. This tells us we are looking to see, is this a healthy baby in there? It's a good, if we have a good non-stress test, we call it reactive. And that means we saw these 2 accelerations within 20 minutes. The baseline looked good, so the heart tones look good, okay? And again, we'll go into more detail next week on this. But it's a good indicator of normal fetal autonomic system functioning, okay? So is that autonomic system of the fetus functioning properly? If we don't get a good NST, and I make sure you understand this, I think NST and BPP are on the exam review. If the non-stress test is non-reactive, okay, so we want reactive, that means good, everything looks good, the autonomic system looks good. If it's not reactive, we don't see those good things we want to see on the monitor, they will proceed to do a biophysical profile. And that's where they put an ultrasound on the abdomen, and they look at different functions. They look at the amount of amniotic fluid, make sure there's adequate amniotic fluid for that baby. They look at different gross and fine motor movements of the baby, and that type of thing, to see, is this baby going to be better off staying inside of mom? Okay, it's out of 10 points. Each category is worth 2 points. If they score 8 to 10 on the BPP, that's a good sign, and we'll probably just continue to monitor. 10 is perfect, so we don't really need to do anything else. So that's a good sign. We don't need to deliver this mom right away. If they score less than that, then definitely we need to either do some further monitoring or possibly proceed to delivery, maybe a C-section and things like that, because this baby is not going to do better inside of mom. And then fetal movement counts, so teaching the mom how to count movements of the fetus. We'll usually have the mom do this, especially later in pregnancy. As that baby gets larger, a lot of times those movements are harder to feel because they're not as large of movements because there's not as much room for that baby to move around. So usually what we'll have to do is have the mom eat a small meal, something to get the baby moving around a little bit. Lay down on their left side. Left side is the best position for pregnant women. It optimizes blood flow on their left side. Keep their hands on their belly, count how many times they feel the baby kick, roll, any type of movement they feel in the baby, and see how long it takes them to get to 10 movements. If they feel less than 10 movements in an hour, they need to repeat it, and so on and so forth. We'll kind of teach them about that. So again, it's just looking at fetal well-being. I see somebody put that her baby had 2 biophysical profiles, first scored 8, had another one an hour later and scored 5. Oh, wow, that's interesting. Yeah, 5 is really low, so it's surprising that it was so shortly after the first one that it was that much lower. So obviously there was some type of compromise going on that baby would have scored so much lower. So, oh, I'm sorry. I hope everything was okay with that delivery, though. Good to hear. All right. Some of the danger signs for first trimester of that pregnancy, we look at if that woman's starting to have some spotting, some bleeding. So is this woman looking at maybe aborting, or there's some type of cervical changes, something going on that's causing that bleeding, something wrong with the placenta, who knows, okay. Painful urination, so looking for signs of infection, persistent vomiting. I mean, if that woman cannot keep her food down, baby is ultimately not going to get what it needs either eventually, okay. Fever, again, signs of infection. Lower abdominal pain accompanied by shoulder pain is very indicative of women in that first trimester if they have an ectopic or tubal pregnancy, okay, which means, yes, the woman is pregnant, however, the pregnancy developed inside the fallopian tube, okay. This baby is not going to survive inside the fallopian tube. It's not an environment for a pregnancy. It's not going to be maintained, but what can happen is that tube can rupture and moms can hemorrhage, ultimately can be deadly to the mom if it's bad enough. So those are signs and symptoms we want to be aware of, okay. And important of, assessing pregnancies and things like that. Those first ultrasounds too are huge if we're not sure of dating and things like that. Also making sure that that baby has been implanted, fetus has been implanted within the uterus and not the tubes. Especially if mom has a history of this, ectopic pregnancies, she's more likely to have more, so we really want to be cautious of that. Second trimester danger signs. So regular contractions, again, second trimester is just kind of that middle part of the pregnancy. So we're still preterm, we're still too early to deliver, okay? So we don't want her to start having regular contractions. We don't want her to, deliver this baby early. So think about those estrogen and progesterone, what hormones might be altered if she's starting to contract. Pain in calves, so sign of those DVTs, those deep vein thrombosis. Sudden gush or leakage of fluid from the vagina, so thinking that amniotic sac has ruptured. We don't want that to happen. Again, remember that amniotic sac cushions, protects that baby. It's also a barrier to the outside environment, okay, by keeping that sac intact. And once that's broken, now we have increased risk of infection. Obviously, the fluid's going to leak out, so you're going to decrease that fluid, and chances are mom, will probably deliver early once that sac is ruptured. There are instances that sac can rupture early in pregnancy, just kind of get like a little pinhole in it, and sometimes it can seal back over, okay? So if you think of what we're doing with like an amniocentesis, we're putting a needle through the abdomen, we're putting a needle through the amniotic sac and withdrawing fluid. We pull the needle out, but that sac kind of heals over and seals back off, okay? So it does have that capability, but if the hole is too big, it's not going to do that. If mom's not feeling that fetal movement, so again, looking at those fetal kick counts, bleeding, back pain, so looking for signs of like kidney pain. Also, back pain can be a sign of labor and contractions, so we want to look for that. And then in your third trimester, if a patient starts to have sudden weight gain, we look at edema, so that increase, especially around the eyes and the facial edema. A lot of these listed here on this page indicate a sign of preeclampsia, which we'll talk about in a few weeks. But it looks at like when the blood pressure elevates within the woman. Can cause a lot of complications, but a lot of these women with preeclampsia, they start to have too much protein in their system. These are some of the signs that they will show. So sudden weight gain, this edema, upper abdominal pain, so where the liver is, will start to have pain as that starts to get inflamed. Headache with visual changes, so due to the increased pressure and swelling around the eyes and in the head, they'll have those headaches and visual changes. Decreased fetal movement because the blood flow starts to slow down when that blood pressure increases. Decreased fetal movement because baby's not getting what it needs, not getting enough oxygen. And then any of the previous mentioned danger signs in that first and second trimester, those are still danger signs throughout the pregnancy too. And then just a generalized feeling of not feeling well or something's just not right. Women can be very intuitive to their bodies, especially pregnant moms. So we never want to, disregard when a woman comes in and says that. I don't know how many patients I've had that have come in and just they really don't have any concrete symptoms that you can really put your finger on. Most of these preeclamptic women that we see, that is their biggest complaint. They just don't feel good. They just generalize kind of just malaise, not feeling good, that type of thing. And they end up, I've had women come in just complaining of that and a few hours later have a seizure because their blood pressure was so high. So it does happen. But these are things that, I think that's the last slide. So these are things that we really want to make sure that we educate our moms on things to report, reasons to be concerned, reasons why when these women come in for their prenatal visits, we are educating them on this, and we are also asking them the appropriate questions to get this information from them, okay? We want to make sure that we are triggering them to think about these things and continue to report them, making sure they understand, what's normal, what's not normal, what should they report, what shouldn't they report because it's normal. Okay, so the better you're educated on this, the better you can educate your patients, excuse me, on it. Okay, I don't see any other questions.